Bismillah ar-Rahman ar-Rahim. My steps in repairing baby's retina. How baby's retina differs? Baby's retina differs from the adults in several points. Small eyes, adherent posterior hyaloid, immature pars plana, relatively large lens, and different anatomical landmarks. This is a 2-year-old child underwent cataract extraction and IOL and was complicated by a complicated surgery with a vitreous wick. The decision was to follow up. This decision is acceptable in adult, but in child, this is the results: a giant retinal tear and retinal detachment. Why? Because the babies have very strong, well-formed vitreous, which exerts strong traction on the retina. So, pediatric and especially the ROP surgery is different from the adult's maneuvers, and it requires proper training. My talk will be about the stage 4A, in which there is partial retinal detachment sparing the fovea. The activation of transforming growth factor beta causes the contraction of the fibrous tissue occurs along the various vectors. The vectors include ridge to ridge, ridge to optic disc, ridge to anterior, and contraction of those vectors leads to total retinal detachment. So, our goal in the surgery is to relieve the vectors of traction. Preoperative consideration: the key element for success in those patients is when to operate. The stability of detachment is unpredictable, and the more advanced the detachment, the worse the results. So, the time frame for an effective treatment is short, and the window for surgical opportunity is also short. So, early vitrectomy for stage 4 ROP leads to regression of the new vascular activity, retinal reattachment, and favorable results reaching 100%. So, fixing initial detachment is the last opportunity to preserve the vision in those babies. And stage 4A is the therapeutic surgical window that cannot be missed. What is the difference between those two pictures? The difference is the active vascularity. The active vascularity leads to risk of uncontrollable bleeding and surgical failure in those patients, so we should operate on a vascular inactive or quiet eye rather than an active one, and this is achieved by preoperative anti-VEGF or laser. The advantage of the preoperative anti-VEGF over laser that it allows the vitrectomy to be carried out at early stage and allows the retinal vascularization continues growing toward the periphery later on. So again, our goal in the surgery is to relieve the vectors of traction, but in the same time, we should avoid any iatrogenic breaks and avoid any intraoperative or postoperative hemorrhage. We start with the lateral cansotomy to widen our field. Conjunctival periotomy is essential in order so we can suture the sclerotomies at the end of the case to avoid any postoperative hypotony and any postoperative hemorrhage. Sclerotomy's position should be planned according to the preoperative examination away from any anterior traction, and it is placed 1 millimeter from the limbus. It is placed perpendicular to the iris rather than pointed toward the center of the eye as in the adults. The cannulas may be too long to allow the access for the periphery, so we may insert the instruments directly through the sclerotomies. The infusion cannula site should be planned at area of least dragging, and take care it may be clogged by the vitreous causing intraoperative hypotony while working. Dealing with the anterior vitreous is an essential point. Anterior vitreous is important in pediatric retina. We cannot deal with the posterior vitreous without dealing with the anterior vitreous. Vitreous is very strong. Traction by the instruments at the sclerotomy will pull on the periphery of the retina, causing giant retinal tears. Then we deal with the posterior vitreous, dissecting the traction proliferations. But the challenge in the pediatric vitrectomy is the pediatric vitreous. It is very clear and formed, and vitreous cannot be easily visualized as in adult. So maybe it depends on signs such as movement of the underlying retina and the relaxation of the attended retina. But is this enough? No, it's not enough. The picture on the left, I thought that I removed the whole vitreous, but by injecting Kinacort, I found that a huge amount of vitreous is left behind. So injection of Kinacort is essential. After removing of the vitreous as I can, is this enough? Yes, this is enough. We should avoid aggressive membrane peeling and avoid any iatrogenic breaks that may cause massive fibrous proliferation. And these fibrous proliferations atrophy with time, and the patient will be fine. Laser photoablation into a vascular retina is controversial. Tamponade with helium is the preferred, and at the end, suturing of the sclerotomy. Don't miss at the end of the surgery to follow up the IOP refractive treatment and managing the amblyopia. So at the end, pediatric vitrectomy is challenging, and pediatric vitreous is an important role in pathogenesis and in the surgery tactics. But the most important strategy in dealing with pediatric retina is better call Saul. But for me, better call Professor Hani Hamza. I would like to thank Professor Hani Hamza. Words cannot express my gratitude to him. I call him before and during and after every surgery, and thank you.